So here was a male patient who presented with history of trauma. So obviously we'll be looking for ADH, SDH or any fracture. As I was scrolling down, I could see area of hypodensity, and it's definitely abnormal, and it is not as hypo as our CSF. So in case of trauma, maybe we can think of subdural hygroma, chronic subdural hygroma, but this is not the site for it. And also when I am seeing the coronal non-contrast image, I can see now properly that they are extraaxial. This is the tentorum, and these are infratentorial. The CSF intensity, when I compare, it is different from that of the CSF in the ventricle. So definitely this is not CSF intensity, ruling out our subdural hygroma. And I can see few area of hypodensity in the cerebellum. And when I'm scrolling, I can see it tracking through and going into foramen magnum. And later on in bone window, when I'm comparing both the area, I can see that there is erosion of the inner table of the mastoid out, and also near complete opacification of the left mastoid, suggesting there is mastoiditis, and it is infective because it is involving the bone. Whenever I'm looking for bone abnormality, I have to look at the ossicles. Malleus incus look pretty normal when I'm tracing the cranial nerve 7 from internal auditory canal to geniculate ganglion through the tympanic canal. It is coming out through stylomastoid foramen. It is pretty normal. Compared to left or right, obviously this is abnormal mastoid, and contrast did not help us much, but showed the like faint enhancement, suggesting it may be some collection, some abscess, and our sinuses look normal. The main worrisome was sinus, because if there is any thrombosis of transverse or sigmoid sinus, uh, we have to find the foci of septic emboli. So it is again a real emergency. Later on, patient was advised for MRI. Here now, let us see first in T2 how it looks. So T2, we can see the area of abnormal flare hyperintensity, T2 hyperintensity, and this is not as that of our CSF, and it is involving the left cerebellum. So definitely there is the left cerebellitis, and this is the mastoid. And on flare, we can see again in there are debris in the ventricle in the occipital horn, and whatever collection we saw, it is not CSF because it is not suppressed on flare. It is involving the left cerebellum, and again flare hyperintensity seen also in the mastoid region. Coming to the contrast images, so now we can see properly the collection with peripheral enhancement, and here these are the tiny micro abscesses which are in contact with the mastoid. So on coronal, it is confirmed. These are the micro abscesses in contact with the mastoid. So this was a case of acute automastoiditis with subdural collection, subdural empyema, and left cerebellitis. So that's it. Thank you.